and lovely to be here today. It's been a fabulous day. I hope you've enjoyed it. The hardest bit's been deciding which session to go to, because there's been lots of different things at the same time. So yes, as Lisa says, I've got a new role that's focused on digital innovation, and I'd like to tell you a little bit about that. I will canter through some of this, because I think some of it you'll have seen before, and that should give us a chance to have some questions and answers at the end. Can I check, can you hear me all right, or do I need to belt a bit more against the noise? We're getting a thumbs up. If I go a bit quiet, would the people at the back mind giving me a wave, and I'll try and go louder. This is the stuff that you may already have heard of, but just in case you don't know what NHSX is, it's a new joint team come together from people across the NHS, England and improvement teams, and those in the Department of Health and Social Care, really to try and accelerate the pace of what we're doing in digital across the NHS and social care. These are our mission statements. They sound deceptively simple, I think, making sure citizens and staff have the technology they need. But the devil is going to be in the detail and in the implementation of all of these things. And the final one about creating an environment that supports and encourages innovation is one that definitely speaks to the work that my team is seeking to do. We have a number of priorities. I'm not going to go through all of them, but just to notice how prominent standards and interoperability and open APIs are within that list. And the 5 missions. No NHSX presentation could be complete without a mention of these. The work I'm going to talk about is particularly linked to Mission 1, reducing the burden, and Mission 5, improving health and care productivity. So, since the 1st of July, I've been leading a new team focused on digital innovation, and we are covering 5 areas. Looking at digital health innovators and how we can work more effectively together, leveraging better value from the larger companies, not just the global tech companies, but big companies in general. Working with a range of stakeholders and partners, because what is terrific is that there are a number of organizations who really care about this space, assets in the system who can work together with us to help provide local reach that a national body isn't able to do. Supporting a number of key priorities, and I'm going to return to that in a moment, and I also lead the communications and engagement team. And you might have noticed that one of the principles I mentioned right at the beginning was about being forensic about user need. So we felt we couldn't embark on creating a new team in digital innovation without actually asking digital health innovators what they would like us to concentrate on. So NHSX was stood up on the 1st of July, and on the 4th of July we held the first of a series of events, that one jointly with Tech UK, with around 120 digital health innovators, to ask the question, if we just were to do 1 or 2 things, what would you like us to focus on? We explained that these are the things we seek to do, and we've got knowledge that sometimes national teams can help or hinder, and other times local teams are what's needed. So we held that event jointly with the Accelerated Access Collaborative, with the AHSN Network, with NHS Digital, and with a number of the accelerators as well. We wanted to do that as a collective exercise. And we've written up the results of that exercise, which then ran for another 2 months. We had hundreds and hundreds of suggestions of the things that we could do. What was really interesting to me was it was very easy to cluster the top 5 things. Huge amount of consensus on the 5 areas that people would like us to concentrate on. If you'd like to read the full report, it's on the NHSX website under Get Involved. These were the top 5 themes by a county mile. Standards and interoperability. Get firmer, be clearer, and enforce, where necessary, standards to ensure that digital health innovators are given the same chances as some of the incumbents. Procurement was the second strongest theme. How we approached scale was seen as really important, and the tone and the manner and the openness of engagement. What surprised me that reached the top 5 was what innovators said to us it made the most enormous difference, the level of digital confidence and how inspired the clinicians and operational managers they were dealing with in organizations were. So the work we're doing on digital capability was great, but could we scale it up even further? And you will have heard, those of you who were at Matthew's session this morning, we have invested significantly in the digital ready workforce activity that Health Education England is leading in the year ahead. But this is something that we need to constantly think about, how we can help board level leaders and others who aren't technologists by background realize that digital transformation is part of their job. I was a chief exec of a hospital for a while. 10 years ago, it might have been acceptable to say that you didn't really see the potential in digital. Nowadays, that is not possible. I was speaking to a group of directors of ops and chief operating officers and said, I wish I had been an ops director now, not when I was, because the tools that are available are fantastic. The crime would be to not use them to their full extent. And on procurement in particular, we've been able to open a new lot on the HSFF framework, lot 0. It's had a huge response. We're delighted about that. They're being evaluated at the moment. And that was all about trying to create a category that didn't have accidental disincentives for some of the smaller companies. So we're eating and breathing these 5 things, and we are working with colleagues across NHSX to ensure that they are consistent priorities. And it's part of a sort of larger scale piece of work looking at how we work with innovators. I mentioned linking really strongly to the great work that's happening across the Accelerated Access Collaborative, a series of open innovation surgeries, creating a clearer pathway and description of the innovation landscape. Looking at evaluation, there are some evidence gaps in some of the tools that we've got. Can we help close them? Think about some of the larger companies and having a clearer way into the NHS with them. And artificial intelligence, you will have seen the massive AI award that closed just today, where we're trying to use that to very practical ends to get products that are getting fantastic results in a research and development setting into clinical mainstream practice more rapidly. And then the final area is about scaling adoption, looking for the strongest evidence-based tools and getting them consistently to more people. Matthew talked a little bit about this morning. In the operating guidance to trust this year, it talks about the fact that we will do this work together with regions and partners to look at getting those things that particularly save clinical time or speak to the digital outpatient challenge more consistently across the country. So these are the 2 areas of our focus in the year ahead. And just to give a couple of examples and a bit of flavor to this. So shift booking apps are enormously popular with staff. We still, though, spend £2.5 billion with agencies every year. There will be somebody on a yacht in the Caribbean at the moment on the taxpayers' expense. There is more to go after here. And what trusts that are putting in shift booking apps that their staff really find is there's a big shift away from agency to bank, particularly if next day payment can be organized. Instead of paying staff maybe a month or 6 weeks after the shift, paying in real time makes an enormous difference. Staff satisfaction rates rising really dramatically. And we've assessed that if these were used absolutely consistently across the NHS, and that's in mental health, community settings, primary care, and acutes, the saving would be over £1 billion a year. And I think we could use that money well across the NHS and social care. Second example, and the picture here, just in case you're wondering what that photograph is. So there are 20 million outpatient letters sent by the NHS every year, and that's a glimpse of a forest, because I kind of imagine there must be quite a large NHS forest being chopped down to keep these letters circulating. We're the biggest users of second-class post in the world. In cities, those letters are often going to addresses that people used to live at. The carbon footprint is pretty grim, and if you've ever been the recipient, it can be incredibly difficult to actually change that appointment to a time you've got a chance of attending. So across the country, people are doing great things in this space around digital letters for outpatients. Nottingham has done fantastic work. It's been working with doctor-doctor, and it's been stratifying patients. And they've achieved that 30% reduction in cancer specialties. So not even the easier ones to go after, but they're bringing patients back who need it more rapidly, and those that don't are being remote monitored. In Portsmouth and also in Southampton, patient portals are being used to the same effect. And in Milton Keynes, they've been working with Zesty to do a very similar thing to enable patients to book their appointments. The ability to send patients across your entire waiting list a notification of a last-minute appointment, patients absolutely love it. The patient satisfaction scores for these tools are off the scale. DNAs drop within 6 weeks of implementation. Oh, and you save typically £2 million per organisation. It's huge. And yet, these two examples, shift booking apps, digital letters, lots of activity across the NHS, probably the number of trusts that are doing both of those things is a handful. So could we be clearer about the types of things that really ought to be part of the NHS, everyday practice? And could we accelerate that by working intelligently across our networks? Matthew talked about the fact that it's all about people and deployment. It's not really, the technology's not the hard bit. So if we could give people funds to invest in that deployment part, in the change management, would that help accelerate uptake of these types of productivity-enhancing tools? I mentioned before that we're working in partnership with lots of other players in this space, including the Accelerated Access Collaborative and the AHSN Network, who've already got some real wins on the board in terms of driving up uptake of digital products such as HeartFlow, which you may know has had the fastest uptake of any country in the world due to the support and boots on the ground, helping trusts give them that bandwidth locally for innovation adoption. Finally, just a word on AI. So we've done quite a lot of publishing, including artificial intelligence, how to get it right. A publication written with chapters by different expert partners across the NHS landscape. This really is a collaboration. The AI Lab is incredibly exciting, so £250 million over 3 years to create really a leading AI institution in this country. The award being the very first aspect of that closed today at 1 o'clock. I saw some photos on Twitter of people slightly desperately getting their bids in backstage. But that's going to be very important. There's a second round in July, if you didn't meet that first one, as a way to get some of these practical solutions into the hands of the people who could benefit most. And really, we're seeking our USP in the UK to be the place that safely accelerates the use of ethical AI to benefit citizens and staff. And I think we've got a good chance of being the country that does that. And the development of a real ecosystem with big players and small players working in harmony, such that the UK is a world leader. I'll stop there. I'm very happy to take any questions. Thank you. Gentleman right at the back. Yeah.
Hello. So you mentioned earlier about the need for evidence base. How are you going to balance that with the agility of innovation, the need to trial things, pilot things, without having more pilots than BA, kind of running joke on that? So how do you balance the two things about having the right evidence base to scale, but then having...
So I'm completely with you on the more pilots than BA thing. I think what we can't have is everybody insisting that the evidence has to be replicated in their own organisation. We've got to be more trusting of the evidence base. I think that we've now got, the evidence base for digital is a bigger conversation, and people will probably know there are 350,000 apps about health and care on app stores, and the research on apps that people like and apps with an evidence base shows an inverse correlation, right? So there's a lot out there that's not meeting evidence-based requirements. But we do have processes in place. So we've had for a while the developer assessment questionnaire, and last week we bundled up all the requirements into a new digital health technology standard that's out for consultation, and we'd love your views on, actually. Which is about making it clearer how you meet the expectation of the NHS. That will be consistent across things like the apps library, across procurement frameworks, and so on. That people need to demonstrate that level of evidence. And I think the other thing is that we do have processes in place, such as accelerator programs that really scrutinize the evidence and select candidates. We don't necessarily make the most of those, because often they are selected as candidates for scale. We think of things like the NHS Innovation Accelerator, that people ought to be looking towards those if they've got a problem in that area. So I think there's more we can do, and one of the pieces we are looking at particularly is closing the evidence gap around financial savings, because I think genuinely it's sometimes hard to trust the company with the value that they may say that they're saving, and maybe an independent piece of analysis on that could be useful. But I think actually we do have now quite a lot of evidence. It's about gathering it up together and saying, you know what, we're going to have to trust that if this has happened in one part of the NHS, let's go with that and scale it rather than start from the very beginning all over again. Yes?
Tara Amitkai, Royal Free Director, Research Director. This has been such an exciting day from Matthew's talk to yours, and it's lovely to see this beautiful program. On the other hand, we've talked about publishing evidence-based, not doing pilots. Are you also setting up a good mechanism of where harm has been done so that we don't do the same mistakes everywhere over the country where there have been? Is there a mechanism we can do a yellow card reporting for drugs? Can we do something for digital tools or digital interventions? Is that in the plan?
So it's a really interesting question. And one of the things that Matthew did say was about capturing the information about failure as well. And we're not good at that at all. He was also telling me that Francis Maud in the civil service created an award for failure so that people would step forward and claim they had an outrageous failure and they wanted to, but it had to be scrapped because everybody had a success that, you know, it was kind of like secretly it was a success in the end as opposed to a proper failure. So I think we do have to be much more open about trying to share the good, the bad, and the ugly. I do think the blueprinting movement is really helpful for that. So we are seeing across the GDEs and the fast followers, people who really want to share what they've been through with others. And we'll also pick up the phone and just have a chat, because often it's about that as well. So yes, I think you're absolutely right. We need to capture what's not good. And we also need to be confident if we think something is snake oil, to shout it out. You know, give feedback to the people involved, but also not persist in suggesting that people try things where other people have had a poor experience. But tough to do, but that we are going to try and do that. This gentleman, thank you.
Hi, Tara. You made reference to the people aspect of this, and it was this morning as well. I often use the term disruptive technologies deliberately because the requirements to make a lot of the innovations, whether it's in AI, work and be used is to recognize the disruptive nature of it and how that impacts people and their jobs and their roles. It's notorious, it's the UK as being the slow adopter, and it seems to me, as apart from just recognizing it, there needs to be a plan as to how that culture and attitude is going to be changed and how the actual people issues are going to be addressed more effectively than they have heretofore.
Yes, I think you're absolutely right. And the best depiction of that for me was the Accelerated Access Review. I don't know if people have seen that, but it shows very clearly how things like the UK is very slow to adopt new cancer drugs and new treatments, seriously lagging behind the rest of Europe. And it was for that reason the Accelerated Access Collaborative has been put together, and we have seen really encouraging changes since then, such as being the first country in Europe to allow CAR-T, and some more new drugs just last week. So I think things are changing from that regard, but there is plenty more to do. What is interesting, I think, is that we have beaten ourselves up about spread for a long time, and actually we now do have some examples of where it's really worked. So let's be evidence-based, I think, in our approach and add to the way that it's worked. The HeartFlow example is really interesting. American product, they haven't seen that level of shift, and it's a process that stops you having to have an angioplasty, which can have serious consequences. It uses data from your CT to assess you instead. It's really quite cutting edge technology. That has gone into all our cardiac centres really, really rapidly through a combination of being made available with no cost and having a team of staff on the ground through AHSNs driving uptake. So we know that kind of model of giving people change support and incentives works. I think we have to now go further with it and do more things in that way.